In this video, I'll be explaining hypoglycemia, including clinical features and emergency management, and the impact on diabetic control. So let's start with the physiology. So what does the body do in normal hypoglycemia in a healthy patient? So the insulin decreases, the insulin secretion decreases, increasing epinephrine, growth hormone, glucagon, and cortisol secretion. These hormonal changes combine to increase hepatic glucose output, increase alternative fuel availability, and increase glucose use. However, in some patients with diabetes, this normal protective neurohormonal response to falling glucose levels is impaired. Hypoglycemic symptoms result from sympathetic activation and neuroglycopenic, which is the reduction of glucose to the brain. We'll cover the symptoms in more detail in the next slide. But the only thing that you need to remember that this hypoglycemic response does not happen or is impaired or does not happen at all in a diabetic patient. In some people with diabetes, so what is really hypoglycemia? So hypoglycemia is defined as blood glucose levels which reaches below 4 millimole per liter. And what's the clinical features of hypoglycemia? So it's divided into 4 subcategories, which is the central nervous system, the cardiac, the GI, and adrenergic. So with the central nervous system, you get altered mental state, coma, confusion, headache, and behavior change. With the cardiac, you get palpitations. With the GI symptoms, gastrointestinal symptoms, you get polyphagia, feeling hungry, belching, and nausea. Adrenergic, you get the tremor and the anxiety. So what are the groups that are at risk of this hypoglycemic change? So first we have type 1 diabetic with severe or recurrent hypoglycemic episodes. Those are at risk. Also, patients with elderly patients who are on hypoglycemic agents, for example, sulfonylurea, it's one of them. Also, young patients are at risk, and alcohol intake that can cause hypoglycemia after hyperglycemia. Strenuous exercise in the last 24 hours and critical illness, for example, sepsis, renal, cardiac, or hepatic failure, can all precipitate to hypoglycemia. So we have what are the causes of the diabetes or the hypoglycemia? So it's just want you to remember that it's more common in type 1 diabetic, but also can occur in type 2, which leads to severe morbidity. Usually type 2 presents with a hypo, then a dose adjustment may be required. But what are the causes? So the causes is overuse or overdose of hypoglycemic agents, for example, insulin, sulfonylurea, or metformin, any other dose, any other hypoglycemic agents. Some people have a miscalculation in the amount of insulin required to balance the carbohydrate intake and exercise. Usually it's more type 1 diabetes because they are more insulin dependent. Also, mixed or inadequate meals can cause hypoglycemia, as well as unexpected exercise or error in timing of insulin can cause hypoglycemia. So what are the management? So if it's mild, so you're going to give oral carbohydrate of refined sugar, about 10 to 20 grams. So that equates to 2 times of teaspoon sugar or 3 times of cube sugar. Or 15 ml of Coca-Cola or 15 ml of Ribena, obviously to be diluted, or a glucogel. You need to wait for 10 to 15 minutes to relieve the symptoms. However, if you didn't wait, you may precipitate hyperglycemia and trigger that vicious cycle of hypo and hyperglycemia. Also, upon recovery, A complex carbohydrate, for example, biscuits, breakfast cereal, is used in order to prevent the recurrence of hypoglycemia later on. However, if the patient presents with severe, for example, is unconscious or confused, not cooperating very well to swallow, so you need to give a glucagon intramuscular injection, 1 milligram, or a 50 ml of 20% glucose IV infusion. If the patient is nil by mouth, then once the blood glucose levels reaches above 4 millimole per liter, you need to give 10% of glucose infusion at a rate of 100 ml per hour until no longer nil by mouth and the patient can resume normally. Okay. Need to take care that patients with renal or cardiac disease use the IV fluids with caution and avoid fruit juice in renal failure as well. It's very important. Okay, so the long-term management of a hypoglycemia. So firstly, you need to avoid vigorous exercise and driving should be avoided. Also, do not stop insulin. You need to continue subsequent insulin doses. Regular glucose monitoring for the first 24 to 48 hours is crucial, so to avoid a hypoglycemic episodes once more. And also you need to review the doses of the insulin or the hypoglycemic agents and give a hypoglycemic education to the patient and refer them to the diabetic team as well. Okay. So what happens if the patient has hypoglycemia while driving? Okay, so first the patient should pull over and park the car at earliest safe opportunity. Switch the engine off, remove the keys from the ignition, and move out the driver's seat. Driving should not resume until 45 minutes have elapsed after the resumption of a recorded normal blood glucose level in view of potential delay to the return of normal cognition function. Okay? If significant and hypoglycemia is likely to persist, the DVLA need to be informed. Okay, so the driving authority need to be informed of this just because of the public safety. Okay? And as well as the patient safety. In some cases, changes to treatment with improved stability but higher average blood glucose levels may restore hypoglycemia awareness, and DVLA may then agree to the resumption of the driving. Then a really crucial thing that you need to document this, well documented into the patient notes. You need to discuss it openly with the patient, just in view of any legal implications that may happen in the future. And this is the end of my video. Thank you so much for watching. Thanks for watching. If you like this video, hit the like button. Do not forget to subscribe to be updated of my latest videos.